All right.
I have 12 o'clock noon and we'll go ahead and get started. I'm Becky Royer and I am the Medicare Beneficiary Quality Improvement Lead and now subcontracted by the Indiana Hospital Association. So sent some notifications out and I will put my email to use in chat here in just a couple of minutes. You've joined the Swingbed September Education webinar today with Kerry Dunning, our Swingbed consultant for the State Office of Rural Health. And I just want to take a minute to thank Allie Orwig for joining us and helping support Zoom and helping manage Zoom types of issues. So if you have any questions about Zoom as the meeting moves forward, why, you're welcome to chat Allie and let her know. But I do encourage you to open up chat, click on the button, and you're welcome to chat in questions using the chat function as we go, and I will make sure that those addressed. Or you're also welcome to unmute your line and ask questions directly. And if you open up the icon with the participant list, you'll be able to click on the microphone and open up your microphone and ask questions, or unmute your telephone if you're joining by phone. We did just start a new contract September the 1st, which was the part of the reason for the switch over in my email and moving to the Indiana Hospital Association. So we do still plan to offer a Swingbed certification program later in the year. We'll be able to take on 16 individuals and provide certification education for them. So be watching for updates as plans are finalized. Nothing changes regarding the program. All of our Swingbed webinar sessions will all still be the same. You can still ask all the questions. The only thing truly different for you is the email that you'll be using for me. I sent out all of the handouts. Kerry had several attached to today's program along with Kerry's presentation. And Kerry, you're welcome to go ahead and share your screen now if you would like. That was sent out again earlier today. So you may want to pull those up for reference as Kerry presents the information today. And just really excited to be able to continue to provide these Swingbed programs to you. As far as certification, Kerry does provide the certification information for Hometown Health. We had 17 individuals that completed the program last year despite COVID. So real happy to be able to do that. And I believe all 17 that received their certificate felt that the information was very valuable. So again, be watching for more information in about a month or so. So Kerry, we'll go ahead and turn the program over to you today, and I will watch chat in case people have additional questions. And so take it away.
Thank you very much. We're going to kind of have a two-part today. One, because it is a new year of services, and I want to start introducing some things that might help you ultimately, which is the responsibility all of you have, with COVID aside, all of the responsibility you already had, many of you filling multiple jobs, and the tracking that is required for skilled nursing and the benefit of following your patients, post-discharge, shouldn't rest solely on your shoulders. We are in rural communities, and there are plenty of things going on that you on the phone are very aware of what's going on in your own area. And that can maybe be help with things like transportation. It may be food banks. I'm beginning to hear more food garden sort of planning. It can be health department programs that support, your hospital and vice versa. There are a ton of things going on. So I want to introduce this today, and I'm stopping on this first slide before you panic. This does not mean that you have to do everything that's in this this week or next week or the following week. But when this is being built out in rural communities, it's really, really amazing. And what happens is we have discharge planners and social workers in your programs trying to discharge from swing beds who now have literally a village behind you to make sure there are follow-up calls, other things going on, so that's not always in your lap to try and follow up with what's going on with that patient. So I'm going to introduce it today, and we're going to spend this year kind of working through pieces of it. The second half of it is that I'm going to do that. I just sent Becky all that information, so she'll forward it later. There are a lot of questions coming in, some of which I can answer and some of which I'm actually getting other consultants who specialize in that area to answer for you. And that kind of raised a question in my head to make sure that whoever's doing compliance for your hospital or your system knows about swing beds and has, you know, all the listservs necessary to keep them up with swing beds. There is no way one person can stay on top of swing beds, and you're talking to a person whose only job is to stay on top of CMS, well, among a few other things, but CMS is changing things rapidly. So please make sure you have had discussions with your compliance officer, and when we talk about the second part of this today, I'd suggest that that information be forwarded to them so we have everybody in the loop helping each other. So just some basic things. And again, I'd be curious to hear what you already have going in your areas. I know there are some rural areas, for instance, that have 50-cent taxi rides as follow-up to get them to physician visits and that sort of thing. They've worked out with, you know, transportation people in their community. I happen to go to a church that has a massive garden. We have 5 acres of a garden behind our church. That the kids from the elementary school across the street, the police line up 2 times a week to let them walk across and work in the garden, but elderly come and work in the garden, can take vegetables and fruits. So there's a lot in this that goes beyond healthcare, but it goes directly to where CMS is headed, which is healthy adults, follow up with them, trying to keep people out of head in the bed, which is, you know, as you know, acute and your swing bed settings. LTACs would be in on that, GeoPsych would be in on that. So it's taking more than just us to get things going. So definitions are here for provider resources. I'm not going to go through all the details in this. I do have some questions in how you have looked at it and how recently you've looked at it. We're so caught up in COVID right now for all the reasons that you're very aware of, that we're scrambling to get other things done. And somewhere in your day, if you get 3 seconds to pause, these are some questions I'd love to have you ask yourself and maybe ask those that you work with, which is, you know, what kind of working relationships do we already have in place? For instance, I have it was an attached nursing home to a rural hospital that also has a swing bed program, and Kiwanis Club meets in that nursing home once a month, and the men in the nursing home are invited to attend that Kiwanis meeting. Actually, women too, but the men are the ones that are attending. So there are things where we can have relationships with non-healthcare entities when we need supplies and that sort of thing. Who helps you with that? Is anybody else tracking the services? We talk about having you track for 30 days post-discharge, but are there other people, for instance, if they went to home health, are they tracking 30 days post-discharge? Is there a way to share that information so you're not being the one that, you know, in theory is having to make all the calls? What kinds of services have come up more recently that you may or may not know about, but we haven't stopped in the last 2 years to really have some discussions around them and act on some of them? So these are not formal questions. This isn't a survey. This isn't a questionnaire. This is in your head for now and to getting your team to start thinking outside the box. I'm hearing now, I don't know any better or any less, that maybe by spring that we are getting this under control. I heard that last year too, so I'm kind of waiting with bated breath. But the point is we do have to move on and start taking care of people. Whether this is some part of this is going to be a new normal, just like post the flu pandemic of 1921, there was a major change in healthcare after that too. what stats are being gathered. I'm not going to go through this today, but you can come back and look at this slide and start thinking about what organizations, civic groups, neighborhood watches, others around you that may have statistics that you can use in addition to what you are gathering specifically to patient care. I do want to bring up aging in place and aging in community. Rural communities do this better generally. When I teach this particular end of the business part of post-acute, it's usually city blocks have banded together, and usually there's either a small hospital or doctor's office or church or something right in that city block area that makes them do it. Why is it important? The first thing is everybody that's older is planning on staying in their home. That's that aging in place. Reality is only 43% of those who are over 70 live independently. So 90% want to stay in their home, and only 43% of the guys over 70 at this point are pulling that off. 1 out of 4 over 65 have a fall-related injury. Only 50% feel like they have access to transportation. You can see the other statistics there. The point is, in building a community group that is helping everyone watch patients, whether they are elderly or have chronic conditions, helps keep them out of the healthcare system. And again, the second piece of what CMS would love to see is getting rid of unnecessary visits to the ED, and certainly unnecessary stays in hospitals and swing beds. There's a couple of things that I don't know that many people are aware of, and I don't know the ones in Indiana, other than I pulled some stats earlier today. But there are 2 models, an AARP model. I keep changing the spelling of Massachusetts, and it keeps reverting to that. That's kind of funny. So I'll just call it Massach from now on. But anyway, there are age-friendly communities, and even if you don't have that in your areas, you might want to look at the AARP model and see what they're doing, because they are helping people stay together and in their own homes much longer. And then there is the federally funded Older Americans Act too, and I have put the websites down here where you can get the information pretty quickly if you're interested in looking at that at some point. The one that you do have in Indiana is PACE. There are right now, according to the Indiana state check-in, there's 2 programs, and I'll show you the names of them in a minute. PACE is interesting. It is a capitated payment, but everything is wrapped up into it. And the nice thing about PACE, if you can pull it off in a rural area, it has primary care, social work, personal care services. You can get OT and PT. Meals can be included. The difficulty for rural program at doing this in a rural area is we all already have trouble with transportation, and that's supposed to be included. Adult daycare centers are usually included, and then each state has Medicaid caps or no funds for this project. But the fact that you already have 2 in Indiana means somebody is already working with the state. And there's the information if you want to look at it. But it's easier on the patients, and meaning that they stay out of the head in the bed situation CMS is trying to avoid, because we're getting more interventions earlier, catching them when they're at home before they, really have to get to the ED or have a hospital stay. This was the latest map that was available, and you see there was one in Indiana. When I went out and looked this morning, Indiana, the state page lists 2 PACE programs. So that may be something where you can visit or get other information. I would say this is a project for post-COVID. We're already, strung out looking at lots of things and dealing with lots of things now, and there is a process you have to go through with the application for it. But put it in the back of your mind as something that might help a community, particularly those of you that are in a hospital system. There may be other ways that you can pull that off. I do want to go into some alternative things. We've talked about telehealth a lot this year, meaning as an industry, and certainly in some of our webinars. But I'm hearing more about a paramedicine model, and it's actually intriguing to me. And I've listed a couple of examples here for you. One is that they are doing the calls instead of discharge planners in some of the areas. So the paramedics are completing the phone calls. In California projects, you can see there in the second bullet, they're actually working on helping the uninsured get hooked up with Medi-Cal, which is the Medicaid program in California. And they're acting as a stopgap. They're going by homes until home health can get into the homes, so that they're making sure people are not falling in that first 48 hours, or they have food and that sort of thing. The one in West Virginia actually does things like fall prevention, blood draws, and med recs. We've got one in Virginia that is using paramedics and a social worker to do home visits for high utilizers. Unfortunately, the nickname is frequent flyers in our industry a lot of the times, and they're connecting them to social services, and they've reduced their call volume in that project by 60%. There's a project in Nevada that is taking low acuity 911 patients directly to urgent care, detox, mental health, and so forth, instead of the ED. They've worked that out. And Flagler County, which is about 25 minutes from my house, has patients that are repeat users and enrolled in a program, particularly those that have the chronic conditions. And so they now have paramedics performing home safety inspections, doing education in vital signs. And this year in particular, they're administering vaccines. So I, again, have put the sources for this down below. But I know we're going to be doing telehealth even when we come out of the PHE. But this is another model that is appearing for rural healthcare that might entice you to look at it. So information and what we're looking at is knowing our resources in our community, who are the leaders, what population is served. Is there somebody out there, maybe the county health department, for instance, that has already gathered this information? So there's one source for that you could be handing out as you're discharging patients. And the reason that I'm suggesting this start with swing beds is we actually keep people 10 days, 14 days, 19 days. So we have more time to make the connection to other services than our own hospital-based or outpatient therapy and so forth. And it's a good time because we are asking that both our primary care providers and families be involved in a swing bed stay to kind of get both of them, maybe not so much the doctor, but the doctor knowing what's going on and the family getting involved in the legwork to getting people to the other services that might be available. I have in the handouts a couple of things. If you decide to formalize this as the other communities, so I've got about 90 programs doing this now. So a lot of them are beginning to do this or had started it prior to the pandemic and are continuing it. There's a coordination worksheet that I just did an example. It's for, all for you as a team to sit down and say, how well do we work with this home health? Do we have a rural health clinic, so forth, what's going on with them? And then I did a sheet just for the hospital and just for the swing bed that are blank so that you can use them as meeting notes if you need that. I've also included two Interact. Interact has been around for 15, 20 years now with the nursing home industry. They were actually, the system and all the work was bought out by Pathway and another swing bed or skilled nursing company, but those tools are still available for free. So I've included a nursing home to hospital transfer sheet. I think it has great information on it. So if you're having any difficulties getting everything you need when somebody's coming from the nursing home, that may be a starting point. And better yet, I like the one that is the SNF nursing facility capability list. That should be updated all the time so that your whole team, not just the case manager or discharge planner routinely talking to them, knows what kinds of patients they can take or not take. And then I had some notes from a communication we did with a group where people gave ideas for how they are doing post-discharge patient education. So they're just notes, but I thought maybe that would also entice you to think about how we are handling that first 30 days, which seems to be the magic number at this point. So Becky, I think at this point, what I'll do, if it's all right, if there are questions about this, I'd be glad to answer them. But this is something that we will continue through this year's grant, just so that we can perhaps start moving out in other directions that would be helpful to your patients and ultimately helpful for you. But if there are not questions about this, then I will look at some of the other things that have come up this month. You see anything?
Sorry, right now I'm not seeing any questions and haven't received questions specifically on this. So I think we
Okay.
could go ahead and address others. I'm sure people are just kind of absorbing the information right now
Yep.
and reviewing the
Yep.
documentation. So,
And I think that's all I'm asking you to do at this point. Is we've got to keep moving in the world. We've got to take care of our patients. Medicare isn't going to pay if people are coming into ED or coming into the hospital or swing bed, and it's not appropriate care. We've got to find a way to bypass some of that. And the best way is really to use the strength of what we have in rural communities as we know each other. And we've got other people out there that can help us. So I've had a series of questions come up, which is not unusual. I've had more, and this will go back to make sure your compliance officer knows about the questions and responses that are coming up. So one of the questions was on the mandatory reporting for caregiver vaccination rates with a swing bed. I asked somebody that is just working in that arena only, which is specifically for providers and vaccinations. And the answer I got back is yes, this document does include cause. I have put the reference here for you to look at. And when Becky does send this out, there is a guidance attachment that it's, I don't remember how many pages, but several pages long that I've attached so you can look at it in more detail. This is when you get into it, 41 and 42 are really looking at specifically at what has to be reported. The statement about cause is not clear. And Becky and I were having this conversation when we started the call today. You have to dig through pages to figure out sometimes of cause. And the way I found it in this, and it was pointed out by the person that works in this because she has the same difficulty, was there was a footnote that said that this applied to both hospitals and cause because it changed the conditions of participation. That's how we found it. It was a footnote. It didn't say from the very beginning all hospitals and cause, for instance. So in one breath, we have distinct rules as critical access hospitals. In the other breath, we're absorbed into existing regulations. But those who write the regulations, I don't think understand that they need to say hospital and cause when they're making their mandates, because the rest of the time we're scrambling. So it will be, the guidance is attached for that question. I've got a good question. Unfortunately, I don't have a good answer about IDTs. Interdisciplinary team meetings, and we've been through this pretty much, I think, several times last year. The rules have always said from the very beginning that a physician is supposed to be in the room. It is meant to be a session where everyone working with a patient is sitting there and can go back and forth in person and come up with creative ideas on how to take care of human beings and help them get better, stay better, and so forth. And I've told you the original Medicare law said they could connect telephonically, because I love the word. And so that opened certainly with Zoom, and certainly with COVID, we've used Zoom nonstop. And I don't think that's a problem. The problem will be when we get out of the PHE, what are we going to go back to? And if we go back to where Medicare stood, that means they really want a physician in the room. There is a comment in some corrective language in the State Operations Manual. Appendix PP are the questions that are to be asked by the surveyors when they are doing skilled nursing visits. And in there is a comment about that if a physician can't attend a meeting, he, she may send an NP, EPA, et cetera, in his place. So it doesn't lend to the idea that we can have an NP sitting there all the time. At the same time, before all of you pass out, I have not seen anybody question that on a survey yet. And until somebody questions on a survey, we don't really know how to answer that, except you should know the original rule says, really, if the physician cannot attend, then send an NP. That's the language. So just be very aware of that and make sure that you are trying to address everything that you can. I will say, having an NP or using Zoom is better than nothing at this point. You can at least defend the point that you had the physician involved in the conversations and the discussion and the decision making. And until we get out of the pandemic, I don't think we can do much to solidify how we're supposed to approach this, because right now you very clearly can say Zoom is the safest way to involve everybody, particularly since we're supposed to have patient and a family representative in that meeting. And, you know, if you're coming over from a doctor's office, that's outside exposure. So just be aware that the language isn't in your favor at this point, but there's nothing else I can say to define it, because we've not had a surveyor or state give us a further definition on that. I got a question about, yes.
Going back to that, and there's another question, or a question that came into chat, so I'll address that first. Can you provide reference to documentation that spells out that an NP could attend if a physician cannot?
Yeah, we've had it in other calls, Becky. I'll go back and find it. But yes, there is a very specific line inside of a paragraph inside a document that says that. So let me write that now.
Okay, I think part of the challenge with this scenario too is that it often, you know, some of the physicians don't routinely have swing bed patients, so to work it into their schedule becomes a challenge. They may periodically, and they may already have people scheduled in the clinic along with the nurse practitioner too. So if anyone, not just Kerry, but if anyone has any other suggestions, why we're willing to listen to those. So always
and
trying
remember,
to problem solve.
You have long-term surveyors that can come in and do your swing bed reviews. And that is happening. State of Illinois, I think every swing bed program has now been visited by a state surveyor, long-term care state surveyor. So that can happen. Sometimes your surveyors, depends on what your state has contracted to do, can be the Joint Commission surveyors, who while they're there will also do your swing bed. They tend to be less directive than the long-term care surveyors. The other side of that coin is long-term care surveyors are used to nursing homes. They don't know that much about swing beds. So sometimes you can fill in the dots for them politely, and they actually will listen. I've had more than one state surveyor walk into a critical access hospital swing bed program and ask for a copy of an MDS, because every nursing home has to have an MDS, and that's their starting point for their reviews, and it takes them off guard. So I think the more, if somebody does come to audit, your key element will be documentation, that you involve the physician how in this particular meeting for this person. So even if the physician couldn't meet that meeting that day, what have you written to say how the physician or a physician extender was involved in the process? The perfect goal would be to have somebody that can make it. The other warning I'll put on this is many of you have set meetings. I mean, I love this one, the fact that this one says our meetings are running efficiently. I mean, it makes me scared to even say anything, because if you have an efficient meeting, why would I want to come in and, you know, upset the apple cart here? But remember, if you have somebody that only stays 5 days, you still have to have an IDT meeting before you discharge them. And that's not always going to hit that routine meeting time. So there may be other ways where we can do, a whole lot of people are going to bedside meetings now. That may be something you can do bedside when the physician's going to be around with that 1 or 2 patients that don't fit into your meetings. I'm not going to tell you any way to do it. You've got to make it work for you guys and just stay as close to this rule as you can. But documentation, how you involve the entire team in this discussion will be important. That makes sense, Becky?
Yes, yes.
All right, so the next one was about our activities assessments, and some programs that are using OT, a lot are using CODAs. I actually have 5 swing bed programs that have hired full-time activities directors, and even when the rule change kept them. That's obviously 5 out of all the Swingbed programs in the country means it's a rarity. And the word that caught me in this was that they'd like to get the social workers certified. So you don't have to have a certified activities director in a Swingbed setting anymore. However, I do think you have to have some education involved in that. They have to understand what the activities means. They have to know why are we doing an activities assessment? It's not just because it's to keep somebody having fun in life, though that's a good thing to do. It's how we keep people motivated to want to live. That's how we keep our health issues in track. That all goes back to the healthy person mandates that we're going through in the U.S. right now. So there is a state course has been provided here, and everybody that goes to that state course, the nursing homes still have to have a certified activities director. It will be a very good course. And you will get a lot of information if that's something that your employee would love to get that background. Just remember, it's geared to long-term care residents. So those activities are more long-term than the things you would be able to provide in a Swingbed setting. So you can learn some good ideas from there, and more importantly, you may get a couple of phone numbers or emails from people that are very good activities directors that you could stay in contact with that would be able to help you, work through specific issues. The second thing you need to remember is that on the MDS, there is a section for activities, and that means the equivalent REI manual, that resident assessment instrument manual I've been suggesting you use as a training tool. You can look up the activities, and you can look up the activities section in the manual. It tells you what they're looking for, and it gives examples. That may be helpful for you in helping document or set up a program. It doesn't mean that you have to have something in person every day if you're in a Swingbed setting. And right now, there are very few in-person activities going on, even in nursing homes, unless they close the doors to all outside people during the pandemic. Then some of them are still doing some group activities. I've seen some very creative bingo calls going on where the residents are sitting in their doorways and the bingo caller's at the end of the hall, and they're just doing one hall at a time. I mean, everybody's trying. But the point is, we need to keep people interested in life. And maybe more importantly, for those of you that are on the clinical side, we need to know what they're interested in. This goes back to person-centered care. You've heard me say, I think, I'm a hiker. So it is important, for me, if I end up in a skilled bed and I'm still wanting to hike or walk, maybe by that time instead of hike, that, doing activities that keep me active, getting PT and OT would be helpful for me. But we've got to know that information, and the activities assessment helps us gather that. And then if you want to have more specific information, I have 2 people that work with me, and all 3 of us have activities ideas, and we certainly could get you connected to one of us depending on what your need is. And Becky knows Lisa pretty well, and she would be one of the primary ones that we would be contacting. So does that help with that?
Yes, and I did connect with the state, and I do have a list of approved programs, education programs on activities, so that you make sure that if an individual doesn't have formal training on activities, there are some training sessions that are available and have been approved. So I will send that list out as well.
Becky, the other thing I can send, we've already done this, but I have that Excel spreadsheet where we mark down everything a patient is doing that day. Because activities include telephone calls, activities include family visiting or a minister visiting. Activities can include a specific television show. I mean, you can't turn on the TV at 8 a.m. and have it on all day and say that's their activity. But people, I've seen people come into Swingbed programs and say, I watch Price is Right every day, and you dang well better know the channel and the time to have it on for them. So that the Excel spreadsheet I'm talking about is anybody going in the room. That can be housekeeping, it can be dietary, it certainly can be nursing staff, therapists. But if they see them participating, all they have to do is check a box. Mm-hmm. And that, you'd be surprised if you use that at the end of a stay, that day's pretty filled up by things that that person chose to do. And if nothing else, that's something you can show a survey to show you were paying attention to what's important to them, particularly since you are in short stays and not a person's not living with you. I do have a question I'm not answering at this point. I think there have been some changes from CMS, so I have written a consultant that specializes in that area, and as soon as I get that update, I forward those things on to Becky, and she can distribute it. I got asked to review admissions criteria policy. Just reminder that a surveyor will look for every policy to be up to date. And we have COVID, and that may have changed some of your admissions policy for your swing bed. So one, you want to make sure there is a swing bed admissions policy, not just the hospital one. And number two, you want to make sure it says whatever you are currently doing. So that's just a reminder of that. And then I have, I think now, I don't know how many pages, 7 more pages of 2 updates that have come through. And I'm not going to go through them now because I haven't absorbed them. There's no way you can absorb them, but I am pointing them out. One is the qualifying hospital stay. This goes back to that 3-day waiver, and they really are honing in on this. They've told the MACs to start reviewing for this. So I gather there are a number of facilities that with the 3-day waiver, the doctors, I know in 2 cases it's doctors, so it's not just doctors, but in the 2 cases with doctors, pushed them to take somebody from home because they didn't want them home alone during COVID. They did not meet skilled nursing criteria, and the doctors pushed them, and they did it anyway. You may have some of that pressure on you. If they have not met skilled nursing criteria, then your facility should not be billing that stay. That's just outright. So what the MACs are getting involved in is to see if the criteria is met. Now, how will they do that? They'll probably start with the diagnoses that are listed on the UB04, the claim itself, and then they'll look at the services that were offered, and then they'll be doing a chart review. So there is language I have included in the handouts. Again, Becky hasn't forwarded to him because she can get it in time to do it before the call. That was on me. But the SE 20011 document has been revised as of 9/8, and it very specifically is saying they better meet skill level criteria. So this is another warning. Again, your documentation, whether it's just for this one issue or if it's for everything that we're doing, it has to be there. We've had a lot of discussion about the documentation on second shift nursing. Really being clear that the person needed help, because that defines why we still have them in a swing bed if they cannot go home safely, for instance. And the difference between a patient in the morning and a patient at 9 o'clock at night can be pretty severe. So make sure all your documentation, you're reviewing that. But I have the regulatory update in there. The second one, and this is the one that's taking up 10 pages. As of 9/10, QSO was revised on the testing changes. And I don't want to make anyone dizzy, but I want you to look at the red as I go through the updates. But to get an idea that it has drastically changed. So I have included both the QSO is attached. Now this is for nursing homes. That means this testing is specific to your swing bed. And then in this particular document, there are subsets here and this is coming from what you will see in the QSO. I've just cut and paste, but it will talk about the testing and how often and so forth. So those are 2 pretty big changes that have occurred. And both of those documents, when Becky forwards this memo that I have here, will have those 2 things included. And I have another question and answer thing on COVID that I've included too. So I will start with saying, skim through this. If it is something that you feel like you might be out of compliance with, you have compliance people in your system, and you have people that are doing this, whose whole job is to keep up with the COVID testing requirements. So make sure that they're getting all this information. When we're in hospital systems or even in a single hospital, our people are honed in on hospital rules, often outpatient rules, but not necessarily the fact that skilled nursing has massive number of rules. Make sense, Becky?
Yes, I did have a question emailed to me on the 3-day waivers. Is there specific situations where you have seen payments denied by using the 3-day waiver?
I personally have not seen it, but I've heard other consultants that have seen it. It has started in the last 2 months. And that's when CMS asked the MACs to start reviewing, and they're doing audits. And so, yes, I'm hearing that in the industry, and I've heard it from a couple people that I trust. It was their clients. I've not seen it hit any of my clients. I'm assuming it could hit anyone and everyone because there's a fine line on the need to be in a skilled bed in the first place. So just, again, whatever you do, you've got to document the need to be it. And remember, we've discussed this. I know you can't write this. Please don't write this. We'll all be in trouble. But basically, when you are documenting, you're saying why Medicare is paying for that patient to be in that bed that day. That's what you're documenting. You can substitute. That's what Medicaid. That's what any insurance company. You are documenting why they paid for that patient to be ahead in the bed. And if you look through a day of your documentation and you can't prove that, then you need to get your team together, because it can take one sentence or two from a nurse on each shift, from a therapist, from RT, from a physician putting in a note. It doesn't have to be everything you write says that, but at least once a day. Why is Medicare, why is Medicaid, why is United, whoever, paying for this patient to be in this bed? That's what you're documenting. And if you take that approach and teach that to nurses, please, again, don't let them use that exact phrase. But if you will teach them that, then you're going to be covered when all this stuff starts hitting us.
But you've definitely seen payment for 3-day waivers
Yes.
too. Yes.
Yes.
Applying
Yes.
the 3-day waiver.
Yes, I've seen it in both directions. 3 days approved, with a waiver, and then those that are now getting hit because they didn't have the need for head in the bed.
Okay.
More technically, didn't meet skilled level of care.
Okay. We have just a couple of minutes left for any additional questions. That's all I have right now, Kerry. I know you've mentioned there's lots of things happening, lots of things to keep up on. So I want to assure everyone as we learn new information that CMS is distributing, why we will get that out to everyone. I know that a lot of our hospitals are really challenged with COVID volumes right now, and some of our critical access hospitals are taking COVID patients into their swing bed units from other facilities to open up beds there. So as questions come out about some of those transfers too.
It's not just, we have nursing shortages, but we have staff shortages across the country. We've got programs in multiple southern states that don't have enough physicians to even try to admit somebody, even if they had the beds available. This is a extraordinarily difficult time, and that's why I very carefully tiptoed through that first presentation, because I do think that's what we need to concentrate on this year for multiple reasons. And I want to at least introduce the topic, but I am not I'm not unaware of the strain that everybody's under working in healthcare these days. And I can't thank you enough for continuing to work in the field, and hope that I can support you and get you answers the best way I can.
Well, we appreciate your assistance, Kerry. And that wraps up our program for today. Keep the questions coming in. We'll address them as quickly as possible, and try to find the documentation to support answers. We'll follow up on some promised documentation from today's call, and we'll be sharing the information that Kerry is sharing on her screen right now that she developed just prior to the call. So you will have this to be able to pull and reference at a later date. So thank you all so much. Thanks for all you do every day, and want everyone to stay safe and healthy. So have a wonderful rest of your day. And thanks, Kerry. Thanks, Allie.